Ever wonder what a 24-hour call is like for an anesthesia resident? Me too. I've never done one, but in this video, I'm going to take you through my first 24-hour call as an anesthesia resident at the Mount Sinai Hospital in New York City. I don't totally know what to expect, but I'm going to go ahead and document the entire call so you can find out with me. You ready for your 15 minutes of fame? So it's about 10 till 6 right now, and today's actually going to start like pretty much any other day, which means I'm going to be in operating rooms till anywhere between maybe 3 and 5 o'clock. And then after my operating room finishes up, I'm going to help relieve other residents from their operating room. I know, it's an early start, buddy. After I relieve other residents from their operating rooms, then I'll go ahead and finish out their cases. And then once those cases are done, which could be at any time, it could be 8, 9, 10, midnight, then I'll be available for any other cases that need to be staffed emergently. As far as the cases for today, I'm gonna be in an ENT OR, and so I've got my case list right here. So there's a nasal septum resection, a nasal bone fracture reduction, elevation of depressed skull fracture. So it sounds like maybe somebody took a bad fall or got punched in the face and has several fractures that need to be fixed. And then the last case that I've got for today is a nasal vestibular stenosis that is going to be repaired by our ENT surgeons. So it should be a fun day in terms of the anesthesia that I'm scheduled to do, and then I'll move on to the 24-hour part. It's actually not the first time that I've done 24-hour shifts. When I was an intern rotating through several different ICUs, I did some 24-hour shifts, but this is quite a bit different because I'm actually doing anesthesia this time as opposed to when I was an intern and I was more just managing patients who were in ICUs. I'm definitely not going to be the only person doing a 24-hour shift. There is another person who's my peer, so a PGY2 level anesthesia resident who's going to be with me. And then we also have seniors with us, and there's also an attending. So we have a fairly big team that's going to be at the hospital staffing cases overnight. Typically speaking, the scheduled surgeries end on average, I'd say, between 4 and 5 o'clock, although some go earlier, some go later. But the point of having people at the hospital 24 hours is to make sure that any emergency surgeries that come up can be staffed by anesthesiologists, regardless of whether they've been scheduled ahead of time or not. I'm just about ready to go, so let me show you real quick what I'm going to bring to the hospital. Nothing too crazy, but just a few things for overnight. I've got my scrubs, my pager, and I'm bringing toiletries with me, which I don't know if is necessary. And also you'll notice I'm bringing some hair gel right here, which is definitely not necessary. But if I am able to get some sleep tonight and then I wake up and have to go to emergency surgery, it might be a little more comforting for my patient if I don't look like I just rolled out of bed and my hair's all over the place. So try and keep myself put together just a little bit. Okay, on my way to the hospital, I have a very long commute. It's about maybe 1.5 blocks. Not too bad. So for anyone watching this video from the distant future, it is currently August 2020, which means COVID is still very much a thing, which is why I'm wearing a mask outside, and most of the people around me are as well. Dun, dun, dun. Today I'm going to be spending most of my time in the operating rooms in this huge building, and we have operating rooms in another building a little further down, so I'll probably be there as well. Alright, gonna drop my stuff off in the locker room, get changed, and get to setting up my operating room. One thing I do want to point out real quick, just because intern year is still so fresh for me, is how nice it is to be at the hospital in the morning and not be on rounds. What you're seeing me do right now is my standard setup for the operating room. I use a mnemonic called MS MAIDS, which stands for machines, suction, monitors, airway, IV, drugs, and S for special, which is case dependent. You can check out another one of my videos for a more detailed explanation on what exactly goes into every part of the MS MAIDS mnemonic for an operating room setup. As I get ready for cases in the ENT room today, one of the things that's going to be unique is that instead of using a normal endotracheal tube that looks like this, I'm going to be using a reinforced endotracheal tube that has little pieces of metal reinforcement all along the tube. And the reason that I'm doing that is since the operative site is right around where this endotracheal tube is going, I want to make sure that there's no chance that the surgeon's instruments can actually cut the tube and cause a leak in my circuit. So this is a special consideration for ENT cases. Also just want to take this opportunity to shout out to the anesthesia techs who have already gone through and done a machine check for me. I do repeat it, but it's always nice to know that there's another set of eyes, and have also gotten all of my equipment out and ready to go, so I can literally just get here, pull everything together and get set up without having to go dig through any of the workspaces to get all the equipment I need. So anesthesia, definitely a team sport, and everyone who's involved is really important. Well, my operating room's all set up, pretty much ready to go, but the patient went to the wrong hospital, so we are waiting for the patient to get to the right hospital so we can go ahead and get started with surgery. So now, first two surgeries are done. The first patient had accidentally gone to a different hospital, which I can understand how that can happen. Mount Sinai has a lot of different hospitals throughout New York City, so easy to understand how that may be confusing. But I guess at the end of the day, if anyone's going to go to the wrong hospital, probably better for the patient to be the one going to the wrong hospital as opposed to the surgeon or the anesthesiologist or any of the nurses in the room. So anyways, the patient came, did the case, it went great, and then I went ahead and just started a second case. We went ahead and did induction of anesthesia. I intubated, we got everything going, and then my attending relieved me so that I could come out, have some lunch. I'm eating some very delicious black bean soup that my wife made for me. She's also a dermatology resident and is very active on Instagram if you'd like to check that out. And in about 10 minutes, I have a simulation for pediatric airways. So simulation is a really important part of the beginning of our curriculum in anesthesia. And at Mount Sinai, we do 2 simulations a week for essentially the first 2 months of being here. During sim, we go through all different sorts of emergencies that can come up in the operating room, how to use the equipment, how to use medication, how to approach different types of patients, different types of surgeries. So it's a really important foundation for our learning in anesthesiology. So I've got an hour-and-a-half simulation, and then I'm going to go back to the operating room that I was in. We have a third case for the day, and then as soon as that case finishes, I'll go see what other rooms I can relieve residents from. Generally in anesthesia, we get a morning break. So here it's about 15 minutes, go out and get some coffee, go to the bathroom, and then go back to your operating room, and then you'll get a lunch break at some point. Lunch break here is about a half an hour long. Then towards the end of the day, if we have a long case that's going on and on, we try to get people relieved from rooms so they can go home at a reasonable hour. And the people who relieve the other residents from rooms are the on-call residents. So usually during other days of the week, it's somebody else who's relieving me if my case is going on, say past 5 o'clock or so. But today I'm going to just stay and do as many of the cases as I'm able to. As a footnote to the conversation about having breaks, some people would say that anesthesia is sort of a lifestyle specialty. I don't agree with that, and I talk about that in another video that I made where I discuss why I went into anesthesiology. But I will say that mental well-being is an important part of being a good physician in general, and it's something that my hospital takes seriously, and it's something that the Department of Anesthesia at Mount Sinai Hospital takes very seriously. So it's important for us to get a little break from being in the operating room, make sure we're out at the end of the day at a reasonable time so we can go home, we can study, we can live our lives, and it's all just an important part of being a good physician, is making sure that you've got a good balance in life of having some free time and having some breathing room. These babies that we use for simulation are super creepy. They look really lifelike, but they also look dead at the same time. It's just really creepy. There's not a better word to describe it. Just finished my pediatric airway simulation, and I have to say it was absolutely terrifying. So in our simulation, I don't want to give away too many details just in case anyone who's watching this video actually ends up doing this simulation, but things went poorly, and we had a simulated death, which I think is a little bit controversial, whether there should be any amount of death in a simulated environment. But I think right now, at least at our hospital, the consensus is that something that sticks in your mind like that is going to be a more effective tool for teaching people who are either in training or just recertifying skills that they have already developed. In general, with pediatric cases, what I've heard is that when things go wrong, they go really wrong, and they go wrong very fast. So when I was in medical school, I had done a month-long rotation in pediatric anesthesia, but I was a lot less involved in what was going on in terms of giving care to the patients than I am now as a resident. And so a little bit later in this academic year, I will have a pediatric anesthesia rotation, which, by the way, is its own subspecialty. It's a board-certified subspecialty of anesthesiology. And so during that rotation, I'll learn a whole lot more about the field. So that's why we do these simulations and also have lectures earlier on in our PGY2 year, so that we can start building an understanding of how to take care of pediatric patients, and especially how to react to situations where things go wrong, and how to figure out how to right the ship. Anyways, I'm going to head back to the operating room right now, and we'll finish up either if the second case is still ongoing, or go ahead and get the third case started. So I'll check back in after I'm done with that. All right, so just started my third case for the day and intubated the patient, got everything all set up, and I have a page to go to the operating room core desk to get my assignment for, I guess, whatever comes next, which I have no idea what it'll be, but I'll find out very soon. Okay, just got my assignment, doing an emergency appendectomy. And so I've actually never done an appendectomy before. From an anesthesia standpoint, I think this is a pretty straightforward case. So we're gonna have one IV placed, and we are going to do general anesthesia and insert a breathing tube. Other considerations, we will place an OG tube, so that's an orogastric tube, so we can suction out the contents of the stomach. And then really the only other consideration is to get the case started, we are going to do what's called a rapid sequence induction. It's important to do rapid sequence induction in a case that's emergent, because you don't necessarily know when the last PO intake was, the last time the patient had any food or anything to drink. So in an effort to decrease risk of aspiration, we'll go ahead and intubate using RSI. And I can talk about that in another video, but for now I'm gonna go ahead and get my operating room set up. So pretty much exactly the same thing as this morning. So here we go. All right, I am all set up for the next case, so just waiting for this patient to get here. I'm assuming they're coming from the emergency department, so we'll see how soon they come up to the operating room. Still waiting for the case to get started, so in the meantime, I am doing some preoperative assessments for a couple of patients who are already here in the hospital, and they're going to have surgery tomorrow. So at our hospital, at least, it's routine practice for us to do preoperative assessments the day before surgery, and then if a patient is coming in for an elective surgery, then we'll do the preoperative assessment, of course, when they get to the hospital. So in the meantime, just doing some preoperative assessments and taking in this nice view that we've got as the sun is getting close to setting. Okay, so finished up the laparoscopic appendectomy, and then also went and relieved another resident and finished a laparoscopic gastric sleeve surgery. And so now I get to spend some time hanging out in the call room and waiting for whatever comes next. So let me go ahead and show you what the call room looks like. Voila, here it is. Nothing crazy, just a desk, computer, bed, and my stuff. You'll notice as part of my stuff, I have acquired a new backpack. And so let me show you all about it. This is not just any backpack. This is actually the airway bag for the hospital, which means that anytime there is an emergency that requires having anesthesia, they will call us. And how do they get in touch with us? With the airway phone and the airway pager. So it's actually pretty wild for me, because when I was an intern here, especially overnight, anytime we had any sort of issue, we would call anesthesia for managing airways. This was on patients who were coding and you know, I imagined that one day I would be that anesthesia resident coming and responding to codes, and now here it is. This is the first time this equipment's been handed to me, and it's just crazy to now be that resident who is responding to airway emergencies in the hospital. So we can get calls from anywhere in the hospital. So if they're having trouble intubating a patient in the emergency department or in one of the ICUs, or in the pediatric side of the hospital, or just anywhere throughout the hospital floors, they can call us. So the pager or the phone can go off at any point between now and when I leave at 7 o'clock in the morning. And what I'm excited to do right now is take a look and see exactly what's in this big bag that I'll carry with me in the event that there is an airway emergency that I need to respond to. And of course, you know, I'm a new PGY2 anesthesia resident, so I would not be responding to any of these calls alone. I have a senior resident who I will call, and then depending on the circumstances, may also alert the attending anesthesiologist who's on overnight. So I'm not working alone. I do have a pretty big safety net. Since I've got some free time right now, I want to take this opportunity to look through this intubation bag and see everything that it's got, so that if I end up getting called for an airway overnight, I know exactly where to reach for something when I need it. This feels a lot like one of those unboxing videos that I see on YouTube, and I didn't totally understand all the hype for unboxing videos, but like, I get it now. You know, I am very excited to finally have this bag on me, and I really want to see what's inside of it, so let me share it with you. I guess we'll start right here. This is a bunch of syringes filled with pressors. So this is phenylephrine, this is ephedrine, and these are more syringes of the same thing. So essentially these are medications that are going to help me raise a patient's blood pressure in the event that it's too low. So we've got that. Can't forget labels. Labels are really important for helping avoid medication errors. So these are essential to have with us. Next up, we've got what looks like a whole bunch of brand new syringes and needles. So these will be for drawing up any sort of drugs that I'm going to want to push. In our front pocket, we have, ooh, this is like the mystery pocket. We have chargers. These look like they are chargers for this really antique phone that I have here. So this is the airway phone, and I guess this is just what charges it, since I haven't owned a phone like this in the last 15 years. So I definitely am not going to be able to charge it on my own. Other things in this pocket, PPE, more PPE, which is great. For the most part right now, we don't have many patients in the hospital with COVID, but when we end up in an emergency situation, someone coming in and we haven't had a chance to COVID test them before an emergency surgery, then we do treat them as a patient under investigation, and so we take all necessary precautions. So glad to see that this is in here, just in case I find myself in a situation where I don't know that a patient is for sure COVID negative. Okay. For our main pocket here, ooh, we got lots of stuff. Lidocaine, rocuronium, that's a paralytic agent. Propofol, this induces anesthesia. Have some calcium chloride, which can also help with blood pressure. Epinephrine, more epinephrine. Got like an entire pharmacy in here. Succinylcholine, that's a paralytic agent. Etomidate, also an induction agent if I need to get a patient off to sleep. And then I've got glycopyrrolate and atropine. So these are medications that, among other things, are going to help with heart rate if a patient's heart rate is too low and I need to get it higher. Ooh, this is nice. So this device is called a McGrath. It's a laryngoscope that you attach a blade to right here. So I'm assuming there must be blades somewhere in this bag, so we will look for them. But essentially, this is a tool where I'm going to turn it on here. Great. And then, ooh, look, there's me. So if I'm intubating somebody, then I can see exactly what's going on the screen, and that's helpful for situations where I have, say, an attending who's over my shoulder or a senior resident over my shoulder, and they want to see exactly what I'm seeing so they can sort of guide me. Mac 3 blades. This is all just supplies for intubation. And we've got endotracheal tubes. We also have an airway device called a laryngeal mask airway. So it doesn't actually go through the vocal cords, it stays inside somebody's mouth and provides a reasonably good airway. However, it is not going to provide the sort of protection from aspiration, and it also has some other disadvantages compared to doing endotracheal intubation. But in a pinch, if you're having a difficult time doing endotracheal intubation, this can be something that can help you oxygenate and ventilate the patient, meaning giving them oxygen and also allowing them to breathe off carbon dioxide. I literally have enough equipment in here to provide anesthesia for the apocalypse. It is unbelievable how much fits inside this bag. Okay, well, that is everything inside of this nifty bag. So I hope for patient's sake that we won't end up in a situation tonight where anybody needs to be intubated, but just in case we do end up in that situation, I've got all the equipment that I could need, and I've got a great team of seniors and an attending physician with me tonight. So if there is anything that comes up, I've got a feeling that we'll be able to handle whatever comes our way. For now, I've got some time to just hang out. I may even try to get a little bit of sleep. It's after 10 o'clock. So if I can rest up, I think that'd be a good thing, because I may end up getting called in to do a case. If there's anything that comes in emergently, then I'll staff that case, or it may be staffed by my co-resident who's on call. We're just taking turns, but I think I'm up next because currently he's in a case right now. So we'll see what happens. Maybe I'll just see what people are saying about the latest episode of Selling Sunset.
That had been the running joke of the whole season, was Heather's publicity, Tarek's publicity, and it was constantly being talked about.
You know, maybe I'll just close my eyes and try and get a little bit of sleep. Well, that nap did not last long, because I just got called that there is a patient who had a surgery that was done yesterday, and they appear to be having some sort of complication, so they need to go back to the operating room so that the surgeons can try and figure out exactly what the complication is. So I am gonna go set up an operating room right now, and we will go from there. All right, case is all done. Just dropped the patient off in the ICU, and he's actually doing really well. Seemed to be doing better after the surgery than when he came in, so that's always the goal. And right now, me and my friend, the anesthesia monitor, are just walking back to the operating room so I can drop this off. And it seems like for now, the operating rooms have quieted down. So I'm gonna go put my head down for a little bit, see if I can get a little bit of sleep. Haven't gotten any calls for the airway pager yet, so hopefully it stays that way, but we'll see. Actually, before I attempt to go to sleep, I'm gonna see if there's a little bit of food, maybe a little bit of water. Spent all day volume resuscitating other people, but I haven't really volume resuscitated myself. This looks promising. Boom, look at all that volume resuscitation. You know, I don't have any endorsements or sponsorships on my YouTube channel, but if I got to pick a single company to sponsor me, it wouldn't be anything cool like Figs. It wouldn't be any of the anesthesia equipment companies. No, it would be Nature Valley. These guys have been here for me during a tough intern year, and here they are supporting me overnight during my call. What more could you ask for? I love these Nature Valley bars. I mean, I don't really love them. It's fine, but I'm not gonna complain about free food, that's for sure. Things seem pretty quiet for now. I've got my pager next to me. I've got my bag. So just in case anything comes up, I'll be ready. But for now, see if I can get a little bit of shut-eye. So overall, not a bad first 24-hour call. Was able to do quite a few interesting cases. Got some sleep too. And on average, I'll be doing these calls once a week, more or less, depending on what rotation I'm on. But this was definitely a good way to get started. I hope you found it interesting. Thanks very much for watching, and I'll see you next time.